Yes, there are some indications for use of a nail in pilon fractures. The indications in my book are few and limited, but as we know that people are extending the indications for distal tibial nailing, and I think pilon is an articular component added to a distal tibial metaphyseal fractures that biologically can be managed better with an intramedullary nail. Okay. Um, I think we all know that soft tissue remains a key to success of fractures that extend into the distal tibial metaphysis with articular extension. And they all have soft tissue components of sizable degree, including a lot of them have compounding. And I think it's to manage them with a plant stage approach is what ultimately leads to success. So uh, this case was managed with a stage approach with a fibula first and an external fixator, that followed by medial plating, and then that went on to heal. At 8 months, he was diabetic. Um, but then again, at 9 months, small discharging sinus still persisting. So he has a united fracture. Um, but with a small problem that's still persisting. So what I was saying was that, there's a large component of soft tissue. So I think the use for nailing in distal tibial fractures, typically in the spiral kind of lower third fractures, which are ones very often they say that they extend into the intra-articular component. So you have small undisplaced fracture lines that can be very well usually picked up on CT. And the debate between nailing and plating is like still not settled, with most studies competing against each other. However, I feel that I think one advantage, particularly of nailing versus plating, is that with plating, even with your best of best experience, you will still land up with some soft tissue problem or a secondary procedure like a flap when the skin breaks down. So this is something where the nailing would have an advantage because it's more biological. Okay. And then you have some disasters waiting, like this bilateral pilon with that was operated at about 18 days on one side and 20 on the other side, but the skin blew up, and then you'll end up with a flap and compromised function. So I think if you can nail these fractures, then maybe you may not have the disasters of plating. Nailing itself on its own may not necessarily be, you may have to combine with many other things. So it is one of your armamentarium to preserve biology. And I think it's important that it gives you the option of a minimal invasive and a load sharing implant. But I think it's reserved for a few subset of fractures. Okay. So when you have an open soft tissue compromise, and when you can get this with lesser incisions in a clever way, with a reasonable outcome between 6 to 9 months, then I think you've done a good job with these kind of fractures. Okay. So what about literature support for nailing of pilon fractures? And the evidence is not very thick on the line on that. As I again reiterate that I think the use of intramedullary nail is possible probably for simpler fractures. And then again, for more complex injuries where there are additional components, then I think it's really with the use of with a lot of expertise that you need to nail these. One must remember with nailing for distal fractures is that you always risk axial malalignment if you do not centralize these nails very well, and therefore it's important to get your nail very well centralized. Secondly, very well distal, because you need to get your adequate purchase of your locking screws in the distal fragment. And you must also not forget that you must get your articular reduction as the first step before you proceed on to then reduce the fracture and then proceed with the process of nailing. Okay. So I think you get better axial alignments probably with plates, but with the combination of nailing, you can do percutaneous articular alignment, and then followed with getting a solid nail that is a load sharing device. I think you should be able to be clever to use joysticks. You should be able to use able to centralize the nail with different techniques, including using different blunt trimmers or external fixator devices. And it's important that you get at least 2 balls in the distal fragment, or if not, maybe you need to combine with something. So I haven't nailed that many, but one which I have nailed have been simpler fractures where there was an undisplaced fracture that extended into the distal fragment, and this is where I would use a nail. One must use percutaneous articular reduction devices like cannulated screws and clamps to hold reduction, then fix them. And I think nailing probably on a radiolucent table with the figure of 4 position is advantageous when you're using nailing for pilon, because it allows you to image well, it allows you to work around the articular and the shaft fractures well, okay? And then I think, so we start with the articular reduction, the ability to get your articular reduction, and then using the figure of 4 position to get a well centralized reamer down into as distal as possible. Suprapatellar nailing use has some advantages in getting the nail well centralized, but I think with your standard nailing infrapatellar technique, I think you should be able to get a good alignment with this. Okay, so I think you need to follow good sequence. Important to get the reduction, then get your reamers well in down the line, and then you should be able to image in this position either with supine and then in this figure of 4, and then able to get a well fitting as distal as possible. So yeah, I think you are extending your, so get good length of the nail and good centralized nail is important. So where would this work? Probably in a simpler fracture like this, where you can get a good percutaneous reduction of the articular fragments. Preoperative imaging would be a must in order to visualize what screws will go from where, and then getting your screws, getting a reduction and then screws across, and then getting the nail centralized with if necessary, with the help of polar screws. And then this, if done, definitely gives if you've seen the problems with platings and the disaster, this would definitely be more advantageous versus a plate. Okay. And then union within reasonable time with these complex injuries. Okay. With a good function. But I think in my book, probably a simpler fracture is one where I would definitely think or consider using a nail, but that only with the help of somebody who is an expert at helping with distal nailings. Okay. Another case, similar, use of distractors helpful to get the axial alignment and get the articular reduction closed, and that followed by final fixation. Okay. Yeah, and that's at follow-up. Important to mobilize these patients early and well. Weight bearing obviously is delayed. So what other situation is where nailing is useful for pilon fractures? And I think probably non-unions, where you have the complexity of a lot of these are open fractures and patients with patients who are smokers. I think these are areas where if you have a good articular reduction but the metaphyseal block is a non-union, then the second surgery, nailing has advantages in the presence of previous large big hardware. So I think nailing has some role and evidence support use of nailing for pilon non-unions. As a salvage for bad articular fractures, for fusion, that's where nailing also has an advantage or it can be used, I think. So this is the role for nailing. So the role for nailing in pilon probably I think is limited, I would think so. So I think be selective in the use of cases, but it's definitely useful advantage. I think getting close reduction and getting good aligned nail is important. But I think remember that I think there's a steep learning curve. So I think it's an expert zone territory, and I would like to hear Professor Ramel and Professor Thirachai on their experience with nailing. Thank you.